a few months ago, quite a large medial sphenoid meningioma. But again, you'd access this very nicely through a pterional approach, and you'd expect to get a complete resection of the tumor. You can see the post-op scans there with no real residual disease there. And all of this is done, through the pterional. This is just, sorry, the pictures are moved around here, but this is just showing that you can then start to access more complex locations. So if you wanted to get to the cavernous sinus, I think this is a cavernous hemangioma, shown here and here, and you can see post-treatment. Coming by the extradural approaches is very nice for getting into the cavernous sinus. I'll show another scan where actually you can start with the pterional and you can end up all the way in the posterior fossa. So as I said, this pterional is the building block for doing these sort of more complicated approaches. So this is a chondrosarcoma. I haven't shown you all of the pictures. It went much lower down. It went into the posterior fossa. And again, we accessed all of this via a pterional craniotomy. So great for getting into cavernous sinus. So an elderly patient is interesting, even despite being extradural for most of the procedure, you still see some effects there on the temporal lobe, which she did very well and got a very nice excision there. So you can get to much more complicated areas. I'm not going to talk about clinoidectomy, but again, it's the building block again for if you're going to do more advanced approaches and take on difficult clinoidal meningiomas. I put up this picture here because this is, we see the perforators and vessels going through the tumor. This is a very specific type of clinoidal meningiomas, and they're described very nicely by Al-Mefti. But it's not just about understanding what you do with the pterional, but you then have to really understand the arachnoid, and I'll talk a bit about that later on in the talk. And some of these tumors, most clinoidal meningiomas, you can resect completely and safely, again, by a pterional approach. But this is the one subtype that depends on how the arachnoid forms around the clinoid, and you have no arachnoid separating the blood vessels from this tumor. So it's actually the one type of clinoidal meningioma that you cannot, in my opinion, safely fully resect. Now, I know Vlad will and I have the same view on this. I think a full orbitozygomatic craniotomy is very rarely used, and certainly in Oxford, we use it maybe once a year. But I think you have to understand the orbitozygomatic craniotomy very well. I think you can use the pterional to get to most things, but we would combine that with parts of an orbitozygomatic craniotomy when needed. So you have to understand how to do a full OZ, but you very rarely need to do that, but we would use parts of it. And there are various indications that people talk about where I really think it's not necessary. So these are just some pictures of sphenoorbital meningiomas, and we treat a lot of those where you get this very hyperostotic bone on the lateral wall of the sphenoid. You'll have tumor along the temporal lobe, but you'll also have it usually within the orbit, at the orbital apex. It can also involve the clinoid. And some people talk about needing an OZ for this, and it really is not necessary. This is the sort of ideal case for a very good pterional craniotomy. By taking the muscle down, you'll drop nicely onto the lateral wall here of the orbit. And once you start drilling this away, you get more and more space as you go along. So actually, this is a very good example of when you do not need an OZ, and you'll take you nicely into the orbit, and you're off. And you can see you can drill all the way to foramen rotundum. You can drill down to ovale and get a great exposure just from a pterional craniotomy. And we use a split calvaeal graft, so you can see the inside of the bone's been taken off there to reconstruct the organ, and you get a nice cosmetic result. So this is another example where you do not need it, just a pterional is enough. But then there are cases where you have to go beyond the pterional, and I just want to highlight a few of them. So then, and really for me, one of the main indications would be orbital tumors, particularly orbital tumors in the posterior third, which I think is very much within the remit of neurosurgeons. This is again another very challenging case. It's a malignant solitary fibrous tumor, so grade 3 solitary fibrous tumor. They are vascular tumors, they're very invasive. And this is one where we used parts. Started off with the pterional, and that is the building block, as I said, for everything we do. But you can probably see here that we've made cuts into the orbit. No need to touch the zygoma, obviously, but you can combine that with orbital cuts. Take you right back. You can combine that with drilling of the clinoid if needed, and that takes you very nicely back. And even in challenging cases, you can get a very nice resection. It was not a complete resection, but it was near complete. You see most of the tumor is out. You can protect, the careful technique, protect eye movement, protect the visual acuity. This is normal sort of scarring, but this little bit here is a bit of residual tumor, which we treated with radiotherapy. But nonetheless, the pterional is the building block, but then you can start to add on more complex bits once you understand the fundamentals. This is just another example of, this is a mesenchymal tumor, very low here, and you can get tumors, particularly chordomas, chondrosarcomas that go back towards the joint. So you can see where the, this is pre-op. You can see where the zygoma is in relation to this. And here, just bringing the muscle down is not going to be enough. And then you can just make cuts along the zygoma. So I think, pterional with little additional bits when needed, but most of the time, just a pterional. Okay. So, oh, sorry, just another orbital tumor. This is one we're waiting for the biopsy result, but again, we'll do through a similar approach that I just